Bismillahirrahmanirrahim. Now we have stress urinary incontinence. So type of urinary incontinence, first one is stress. Stress is related with the intra-abdominal pressure. That is, the problem is that there is weakened pelvic floor muscle, and whenever there is increased intra-abdominal pressure, the urine will leak out, like with coughing or sneezing or maybe something else. Then overflow incontinence mean that the urethra is blocked by something. It can be an enlarged prostate or it can be anything else. So due to the blockage of urethra, the outlet can't be opened. So the bladder keeps distending all the way until uh, it starts dribbling downwards. So this is overflow incontinence, and urge incontinence means that there is something wrong or something is stimulating the detrusor muscle. There is due to the hyperstimulation of the detrusor muscle, the urine is leaking out. So that is urge incontinence or hyperactivity of the musculature. So the intermittent leakage of urine associated with increased intra-abdominal pressure is stress incontinence. Causes are weakened pelvic floor musculature due to increasing parity, even in those who deliver by cesarean section, obesity, and chronic high impact exercise such as jogging. Urogenital mucosa atrophy due to decreased estrogen. In postmenopausal women, both these causes interplay and lead to unsupported bladder and hypermobile urethra. Urinalysis and post-void residual volume are normal. Post-void residual volume in women is less than 150 ml, and in men it must be less than 50 ml. Management: Kegel exercises, lifestyle modification, that is weight loss, pessaries and mid-urethral sling. Mixed urinary incontinence management: we should keep a voiding diary. Voiding diary is included in the initial evaluation in order to classify the predominant type of urinary incontinence and determine the optimal treatment. That is by fluid intake. No, the voiding diary contains fluid intake, urine output, and leaking episodes. The bladder training with lifestyle changes, which are weight loss, smoking cessation, decreased alcohol consumption, and decreased caffeine intake. Kegel exercises: pharmacotherapy and surgery in the patients who have limited or incomplete symptom relief with bladder training. Urgency predominant incontinence, we give oral antimuscarinics. For urgency, we give muscarinics and timed voiding. Stress predominant incontinence, we can use the mid-urethral sling. For stress, we use sling, and for urgency, we use muscarinics. In urodynamic studies are not that urodynamic studies are reserved for the patients who do not respond to any treatment or those who are being treated on surgical intervention. For surgical intervention, urinary incontinence, stress, leakage with Valsalva, cupping, sneezing, and laughing. Treatment is lifestyle modification, pelvic floor exercises, pessaries, and pelvic floor surgery. Urgency, sudden overwhelming or frequent need to void. Lifestyle modifications, bladder training, and antimuscarinic drugs. Mixed features of stress, urgency, and incontinence. Variable treatment depending on the predominant symptoms. Overflow, constant involuntary dribbling and incomplete emptying. Identify and correct the underlying cause, cholinergic agonists and intermittent self-catheterization. Overflow, cholinergic agonists. Okay. So in urge incontinence, we give antimuscarinics, right? For overflow, we give cholinergic, which are muscarinic agents, and for stress incontinence, we give support, that is sling. So just try to think about the pathogenesis of each type of incontinence, and you will easily come up with a solution for that. Then we have interstitial cystitis. It is also called as bladder pain syndrome. This is chronic condition with unknown etiology. It is associated with the following: other chronic pain conditions, fibromyalgia, endometriosis, and irritable bowel syndrome, sexual dysfunction, and psychiatric illness with number depression and anxiety. Interstitial cystitis, that is bladder pain syndrome, epidemiology, more common in women and associated with psychiatric and pain disorders, for example, fibromyalgia. The clinical presentation is bladder pain with filling, relief with voiding, similar to irritable bowel, increased urinary frequency and urgency, and there will be dyspareunia. Diagnosis: bladder pain with no other cause more than 6 weeks and no normal urinalysis. Treatment is not curative. Focus on improving the quality of life. Behavioral modification, avoidance of triggers, physical therapy, amitriptyline and pentosan polysulfate sodium, analgesics for acute exacerbations. What is Candida vulvovaginitis? Risk factors that increase estrogen level, estrogen containing contraceptives, pregnancy, sexual activity, recent antibiotics, Uncontrolled diabetes mellitus. Features are vulvovaginal erythema and vaginal discharge. Vulvar pruritus, dyspareunia and dysuria. Diagnosis: normal vaginal pH of 3.8 to 4.5. Wet mouth microscopy shows hyphae and budding yeasts. However, it can be negative too. Do a vaginal culture if wet mouth is negative. Treatment: oral, fluconazole, and for intravaginal give clotrimazole. Then we have intraductal papilloma. They are not palpable because they are less than 1 centimeter in intraductal location. So diagnosis is less than 3 only by ultrasound and more than 3 mammogram with ultrasound. So intraductal papillomas are benign condition. Clinical features are unilateral bloody nipple discharge and no associated mass or lymphadenopathy. Management is with mammography and ultrasound, and biopsy with or without excision is the treatment. If mammogram has no findings, ultrasound may show dilated duct. Only finding is bloody nipple discharge. Features are unilateral bloody nipple discharge is the hallmark. No associated mass or lymphadenopathy. Management is with mammography, ultrasound. It would reveal normal breast tissue and single dilated breast. Biopsy of duct excision for confirmation. Okay. So there is the table that is intraductal papilloma. Pathology is benign papillary tumor arising from the breast duct lining. The clinical features are unilateral bloody nipple discharge, can be non-bloody, and no associated breast mass or lymphadenopathy. Management is mammography and ultrasound and biopsy with or without excision. Rule out invasive ductal carcinoma, also had bloody discharge. Ductal carcinoma in situ, microcalcifications. In Paget's disease, bloody discharge with eczematous nipple with skin changes and leaking and crusting. In Paget's disease, okay. So bloody discharge, eczematous nipple, skin changes, and they will be leaking and crusting as well. So this is the picture of intraductal papilloma. Here you can see lactiferous ducts. A papilloma is over here, and that papilloma is causing the dilation of the duct at the location where it is present, and a unilateral bloody discharge is occurring. Then we have breast pathologies. Ductal carcinoma in situ. On mammography, you will see microcalcifications. If it is fat necrosis, then form irregularly shaped mass findings of oil cysts on the mammography. Then fibroadenoma, solitary, painless, firm and mobile breast which is regular in shape and it is estrogen positive. Fibrocystic change, cyclic bilateral breast pain, and diffuse nodularity on breast exam. Lobular breast carcinoma, fixed palpable breast with irregular borders and can be bilateral. Memory Paget's disease, it is suspected in the following presentation: eczematous or ulcerating rash localized to the nipple and spread to the areola, vesicles, scaling, nipple retraction, and bloody discharge. Most common cancer found in the memory Paget's disease is adenocarcinoma. Management is mammography and biopsy. Then we have physiologic electropia. So the features are bilateral, OEAC negative, that is no occult blood. Appearance is milky or clear, but can be yellow, brown, gray, or green. Medications which cause galactoria are dopamine antagonist, antipsychotics, opioids, and antidepressants. Pituitary electrode stimulant, for example, estrogen-containing contraceptives. Chronic use of histamine receptor blockers, that is cimetidine, and inhibits the estradiol metabolism, increase prolactin. Diagnosis MRI if prolactin is raised, and if symptoms of pituitary mass, vision disturbance, and headaches are present. Intramammary breast carcinoma. It presents with rapid onset edematous cutaneous thickening, which with following features, that is peau d'orange penis. It is something in French, I can't pronounce that. Okay, superficial dimpling and fine pitting. There will be edematous breast, erythematous breast, painful breast, itching, palpable breast mass and nipple changes, for example, flattening or retraction may also be present. Axillary lymphadenopathy is seen, signs of metastasis. Diagnosis is mammography, ultrasound, and tissue biopsy is diagnostic. Differentials are mastitis, presents with fever, improve with antibiotics. Ductal and lobular carcinoma, no edematous or erythematous changes are seen. Dimpling may be present. So these are enlarged lymph nodes, edema, and pure the orange appearance, and retracted nipple will be present. Then we have lactational mastitis. So there will be erythema, induration, and swelling. These are the lobules, clogged, inflamed milk ducts, and clogged nipple pores. Symptoms are flu-like symptoms like fever and myalgias. focal unilateral breast pain with surrounding erythema and indulation, and there will be axillary lymphadenopathy. Most common causative agent is Staphylococcus aureus. Treatment is against methicillin sensitive Staph aureus. We give digoxin and cephalexin. Against MRSA, for example, history of recent antibiotic therapy and incarceration, we give clindamycin, TMP, SMX, and vancomycin. Analgesics and continue breastfeeding every 2 to 3 hours. Differentials include inflammatory breast cancer, adventitious breast and pure de orange, breast engorgement, bilateral pain, generalized involvement, use NSAIDs and warm compresses for relief. Then we have lactational mastitis, pathogenesis, skin flora, for example, Staphylococcus aureus, enters the ducts through nipples and multiplies in the stagnant milk. Risk factors are history of mastitis, engorgement and inadequate milk drainage due to sudden increase in the sleep duration, replacing nursing with a formula or pumped breast milk, weaning, pressure on duct, tight bra or clothing prone sleeping, cracked or clogged nipple pore, and poor latch. Clinical presentation is fever, firm, red, tender, swollen content of unilateral breast, and myalgia, with or without myalgia, chills, and malaise. Treatment is analgesia, frequent breastfeeding, pumping, or antibiotics. Simple breast cyst. It is a benign breast mass. A tender mobile mass in a young patient is most likely benign. In a patient aged less than 30 with a clinically benign mass, breast ultrasound is the first line imaging study. Breast mammography is in the woman aged less than 30 is not recommended because they have relatively dense breast tissue and radiation exposure is potential risk factor for the breast cancer in young women. Features of simple breast cyst are ultrasound will show posterior acoustic enhancement that is indicative of fluid, no echogenic debris or solid components. Symptoms range from asymptomatic to severe localized pain. Management is needle aspiration, which will yield clear fluid, disappearance of mass on needle aspiration, re-evaluation within 2 to 4 months. If there are no further symptoms or signs of recurrence, resume annual screening. If there is a palpable breast mass in age less than 30, do ultrasonogram with or without mammogram. If it is a simple cyst, needle aspiration if the patient desires. Complex cyst or mass, solid mass, image guided core biopsy is done. If age more than 30, mammogram with or without ultrasound. So after age 30, mammogram is the most preferred investigation of choice, and age less than 30, ultrasound is the preferred investigation of choice. So after in age more than 30, after doing mammogram with or without ultrasound, suspicious for malignancy, do the core biopsy. Then we have mastalgia, that is pain in the breast. Management of breast pain. Now for breast pain, look if it is cyclical, bilateral, diffuse. Okay. If it is associated with mass, do the imaging. If it is not associated with mass, observe. If it is non-cyclical, unilateral and focal, if it is associated with mass, biopsy and refer to breast surgeon. If there is no mass, do the imaging. If on imaging you find everything is normal, so observe the patient. If things are abnormal, do the biopsy of the abnormal area. Then we have approach to post-menopausal bleeding. All patients with post-menopausal bleeding require further evaluation with PAP for cervical cancer, regardless of when the last PAP was performed. Endometrial biopsy or transvaginal ultrasound for endometrial cancer. Treatment of endometrial hyperplasia or cancer. Hysterectomy with bilateral salpingo-oophorectomy. Approach to postmenopausal bleeding. For postmenopausal bleeding, we can give transvaginal ultrasound of the endometrium. If it is less than equal to 4 millimeters, do the observation. Endometrial strip is like less than 4 millimeters. If it is more than 4 millimeters, do endometrial biopsy. Right? And you can do endometrial biopsy directly after postmenopausal bleeding. If it is benign, observe. If it is showing atypical neoplasia, then progestins or surgery can be given. Then we have toxic shock syndrome. There are the features are tricks. So T is toxic shock. No, these are not symptoms. These are the causative etiologies. So we'll come to them later on. Features are high fever, hypotension, diffuse red macular rash, which involves palms and soles. Treatment is vancomycin with clindamycin. Vancomycin is bactericidal activity against gram-positive bacteria, including MRSA. Clindamycin inhibits the toxic shock syndrome, exotoxin production. So the etiologies are toxic shock, rickettsia, eyes for nothing, Coxsackie A virus, Kawasaki disease, keratoderma melanoregicum, which is reactive arthritis, Staph Scarlet syndrome, so tricks, rash, and palms and soles. So these are okay. So these are the diseases that cause palms and sole involvement. Okay. So rickettsia, they missed syphilis. That also causes it. So these are not associations of toxic shock syndrome. These are the things that cause, rash in palms and soles. Okay. So Staphylococcus toxic shock syndrome risks are tampon use, nasal packing, and surgical postpartum wound infection. Pathogenesis is Staphylococcus aureus. Exotoxin release acting as super antigens. The clinical features are fever more than 39 degrees Celsius, 38.9, that is 102 degree Fahrenheit, hypotension, diffuse macular rash involving palms and soles, desquamation 1 to 3 weeks after the disease onset, vomiting, diarrhea, altered mentation without focal neurological signs. Treatment is Treatment is supportive. That is supportive therapy with fluid replacement, removal of foreign bodies, that is tampon, and antibiotic therapy with clindamycin plus vancomycin. Disseminated gonococcal infection caused by Neisseria gonorrhea. Presentation is pustular dermatitis, tenosynovitis, and migratory asymptomatic polyarthritis or arthralgias. So these are flexor tendon checks. This is ulnar bursa and this is radial bursa. So, and these are the pictures of something. There is pustular dermatitis, which is like this. So these are the pustules, I guess. This one, these, and this one. Then we have acute pelvic abdominal pain in the women differentials. We have talked about these in a different table before, but let's see them again. So Mittelschmerz, recurrent mild unilateral mid-cycle pain prior to ovulation. Pain lasts hour to days. It is ultrasound findings are not indicated. Ectopic pregnancy, there will be amenorrhea, abdominal pelvic pain and vaginal bleeding. There will be positive beta HCG, no intrauterine pregnancy. Ovarian torsion, sudden onset severe unilateral lower abdominal pain, nausea and vomiting. Unilateral tender adnexal mass on examination. There will be enlarged ovary with decreased or absent blood flow. Ruptured ovarian cyst. Sudden onset severe unilateral lower abdominal pain immediately following strenuous or sexual activity. Okay, that is pelvic free fluid will be seen on ultrasound, and it can cause peritonitis. That is rebound or guarding will be present. Then pelvic inflammatory disease, fever, chills, vaginal discharge, lower abdominal pain, and cervical motion tenderness. Tubo-ovarian abscess, air fluid levels, and internal debris will be seen on ultrasound. Management of acute abdominal pain, do pregnancy test first. If it is positive, do pelvic ultrasound to check for the intrauterine or ectopic pregnancy. If it is negative, do abdominal CT to evaluate for appendicitis or kidney stones. Abdominal X-ray may also be considered to rule out the intestinal obstruction or the perforation, free air under the diaphragm. Investigation for palpable adnexal mass. Pregnancy test and pelvic ultrasound is the first line test. A CT scan of the abdomen and pelvis is indicated if the mass has malignant features. CA-125 has low specificity for initial screening of ovarian cancer in premenopausal patients. It is, however, helpful in postmenopausal patients. Pudendal neuralgia presents a superficial pain located at the pudendal nerve distribution, that is vulva, perineum, and rectum. Then we have investigation of palpable adnexal mass. So firstly do the pregnancy test and pelvic ultrasound is the first line. A CT scan of the abdomen and pelvis is indicated if the mass has malignant features. CA-125 has low specificity for initial screening of ovarian cancer in premenopausal patients. It is, however, helpful in the postmenopausal women. Then we have premenopausal adnexal mass evaluation. So if there is premenopausal adnexal mass, do the pregnancy test and pelvic ultrasound because there are higher chances for it to be ectopic pregnancy. If that is positive, rule out ectopic pregnancy. If that is negative, look for malignant features. If they are present, do the surgery. If not, so conservative management with NSAIDs with or without narcotics. Repeat ultrasound every 6 weeks until there is resolution. Adnexal mass, further evaluation is indicated. Initial evaluation of all the adnexal masses in premenopausal women is with pregnancy test and pelvic ultrasound, which helps further identify the masses. Location with adnexal mass originating from the fallopian tube, for example, hydrosalpinx, ovary, endometrioma, uterus, pedunculated uterine fibroid. Emergent nature by evaluating a fetal heartbeat, blood flow to the ovary, and free fluid in the pelvis, for example, ectopic pregnancy and ovarian torsion. Internal features which can help determine whether the mass is benign, a simple thin walled mobile, or malignant, for example, thick septation, solid components, and immobile process. Fluid in the fallopian tube, hydrosalpinx. Hydrosalpinx refers to the fallopian tube that's blocked by watery fluid. This condition is typically caused by a previous pelvic or sexually transmitted infection, a condition like endometriosis or previous surgery. Then we have Mullerian agenesis. The urogenital development is such that initially every child has paramesonephric ducts or Mullerian ducts, which will develop the female reproductive, internal reproductive organs. There is the genital ridge, urogenital sinus, ureteric bud, and mesonephric or Wolffian ducts. In females, the Wolffian ducts will undergo degeneration. Now the Wolffian ducts are degenerating, and the Mullerian ducts are converting into female genital tract. So here you can see that the Mullerian or the paramesonephric ducts are formed ovaries, uterus, and lower two-third of vagina. Not lower, upper one-third of vagina. The lower two-third of vagina is coming from the urogenital sinus. Okay, ureters are coming from the remnants of Wolffian duct, I guess. Yes, and the ovaries are coming from the genital ridge. Okay, so genital ridge gave rise to ovaries. The mesonephric ducts gave rise to fallopian tubes, uterus, and upper one-third of the vagina. The urogenital sinus gave rise to bladder and lower two-third of vagina. And the ureters are coming from the mesonephric ducts. Also called as Meyer-Rokitansky-Kuster-Hauser syndrome. There is no uterus, no cervix, no upper one-third of vagina. So no uterus, no cervix, no upper one-third of vagina. Everything that was supposed to come from the paramesonephric ducts, that is not present. Features are absent uterus and cervix. Normal secondary sexual characteristics because of the presence of ovaries which are coming from the genital ridge. Normal external genitalia, normal lower two-third of vagina because that is coming from the urogenital sinus, right? Then normal FSH. Internal genitalia derived from structures of the intermediate mesoderm, which develop into paramesonephric Mullerian ducts, makes a uterus, fallopian tube, cervix, and upper one-third of vagina, and mesonephric or Wolffian duct, which makes primitive kidneys. Because of their common embryonic source and synchronous development in the first trimester, internal genital anomalies are common and often concurrent with the renal anomalies. Therefore, women with a Mullerian agenesis should undergo evaluation for the renal tract with a renal ultrasound. Common abnormalities are unilateral renal agenesis, pelvic ultrasound, and duplication of collecting system. Mullerian agenesis. Pathogenesis is Mullerian duct system defect. Abnormal development of uterus, cervix, and upper third of vagina. The clinical features are primary amenorrhea, normal female external genitalia, blind vaginal pouch, also seen in 5 alpha reductase, but they are males. In our case, these patients are females. Then we have absent or rudimentary uterus, bilateral functioning ovaries, normal FSH. Management is to evaluate for the renal tract abnormalities, for example, renal ultrasound, vaginal dilation, and surgical or non-surgical. Vulvar squamous cell carcinoma, HPV, smoking, lichen sclerosis. Presentation is bleeding, vulvar pruritus, unifocal erythematous, parietal plaque or ulcer of the labium majus, and dyspareunia. Ovarian reserve. Women are born with a lifetime supply of oocytes and a sharp decline in the conception rates that occurs after age 35 because decreased ovarian reserve. This is the reason why lack of conception after 6 months of unprotected intercourse in the women aged more than 35 is considered infertility. Features are normal regular menstrual cycle, decreased oocyte number, and quality. Ovarian reserve with aging. So at birth they are the maximum. Then optimal fertility is reached by time 18 and they start decreasing every menstrual cycle. We have loss of at least 14 to 15 follicles, I guess. And then the decreased fertility start happening after age 37 and end of fertility occurs after age 41. Then there are irregular cycles and then there is menopause. So the cervical insufficiency. The clinical findings are vaginal spotting, pelvic pressure, and increased vaginal discharge. In the absence of labor, for example, no contractions and typical symptoms of cervical insufficiency, treatment is cervical circlage. And these vaginal spotting and discharge is happening in the when the woman is pregnant. Cervical insufficiency, the risk factor are cervical colonization or LEEP. A LEEP has a full form, I don't remember what. Okay. Mechanical cervical dilation, obstetric cervical laceration, and uterine anomalies. The diagnosis is prior or current painless cervical dilation, history of preterm birth with current cervical length of less than 25 millimeters on ultrasound. Management is with serial ultrasound on cervical length and circlage placement, that is suture. Then we have adenomyosis that happens after the age of 40 years. It is a disorder caused by abnormal collection of endometrial glands and stroma within the uterine myometrium. Presentation is multiparous woman aged more than 40, new onset dysmenorrhea, heavy menstrual bleeding, chronic pelvic pain. Features are new onset dysmenorrhea, symmetrically enlarged globular uterus, boggy, tender, and does not exceed 12 weeks in size. The enlarged uterus increased endometrial cavity surface area, resulting in concomitant heavy menstrual bleeding, for example, anemia, typically seen in the patients. As repeated menstrual cycle keeps shedding endometrial tissue within the myometrium, patients often progress from dysmenorrhea to chronic dull pain. Diagnosis: initial pelvic ultrasound and/or MRI. Definite is histology after hysterectomy. Treatment: conservative is oral contraceptive pills and progestin releasing intrauterine device. Mostly copper can increase the bleeding. And we can also perform hysterectomy. Adenomyosis, the pathogenesis is abnormal endometrial tissue within the uterine myometrium. Risk factors: age more than 40, multiparity, and prior uterine surgery, for example, myomectomy. Clinical features are dysmenorrhea, heavy menstrual bleeding, chronic pelvic pain, diffuse uterine enlargement, for example, globular uterus with or without uterine tenderness. Diagnosis is clinical presentation. MRI and ultrasound will show thickened myometrium and confirmation via pathology. Treatment is hysterectomy. Erosive lichen planus, there are 6 P's, that is purple, polygonal, pruritic, plaque, again plaque, and pain. So why can't we go with 5 P's? 1, 2, 3, 4. 1, 2, 3, 4, 5. Okay, features are glazed, brightly erythematous, vulvar erosions with a border of serpentine appearing white stria, that is Wickham stria, which causes vulvar pain, vulvar pruritus, dyspareunia, acute vaginal inflammation, pliable mucosa, serosanguinous vaginal discharge, chronic vaginal inflammation, vaginal introitus stenosis, lace-like reticular erosion on the gingiva and palate, painful oral ulcers, plaque formation on the tongue. Diagnosis is made clinically but should be confirmed with vulvar punch biopsy. Treatment is high potency topical corticosteroids, that is corbidazole. Differentials are Behçet disease, painful oral and genital ulcers. Oral lesions do not have associated plaques or a reticular appearance around the gingiva, but ulcers with necrotic base. Vulvar lesions do not have white stria along the margin. The clinical features: vulvar lichen planus, women aged 50 to 60, vulvar pain or pruritus, dyspareunia, erosive variant is most common, erosive glazed lesion with white border, vaginal involvement with or without stenosis, and associated oral ulcers. Papillosquamous variant is small pruritic papule with a purple hue. Diagnosis with a vulvar biopsy in this and lichen sclerosis. Treatment is high potency topical corticosteroids. Then there is something that we call Zika syndrome. What is the difference between Zika syndrome and Sjogren's? I think they're pretty much the same. So impaired function of salivary and other exocrine glands can produce Zika syndrome, which is characterized by generalized dryness of mucous membranes. Dry mouth increase the risk of dental caries, irritated itchy eyes, cough, and vaginal dryness, that is there will be dyspareunia. Sjogren's syndrome, exocrine features are keratoconjunctivitis Zika, dry mouth, silver, salivary hypertrophy, and cirrhosis. Extraglandular features are Raynaud phenomena, cutaneous vasculitis, arthralgias and arthritis, interstitial lung disease, and non-Hodgkin lymphoma. Diagnostic findings are objective signs of decreased lacrimation, for example, Schirmer test, positive anti-Rho SSA or anti-La SSB, salivary gland biopsy with focal lymphocytic cyaloadenitis. Classification is primary if not associated CTD, connective tissue disease, secondary if comorbid, connective tissue disease, for example, SLE, rheumatoid arthritis, or scleroderma. And mostly with one autoimmune condition, there is associations of, or there is presence of some other autoimmune condition as well. Then we have contraception. Copper intrauterine device can be placed up to 10 years, and it is one of the best methods for emergency contraception. Can cause intrauterine inflammation, which is toxic to sperm and ova. Can cause heavy menstrual bleeding. Levonorgestrel containing intrauterine device can be placed up to 5 years. It contains progesterone, levonorgestrel. Long-acting reversible contraceptive. Mechanism is that it thickens the cervical mucosa and blocks the sperm entry, impairs implantation, thins the uterine lining, and decreases the menstrual bleeding. A common side effect is amenorrhea. It is a good option in patients with heavy menstrual bleeding with contraindications to oral contraceptive pills. They are contraindicated in the patients with unexplained vaginal bleeding. Then we have medroxyprogesterone. Injections every 3 months and weight gain is a common side effect. Contraindications of intrauterine device placement. So copper intrauterine device and progestin intrauterine device. We can place them in pregnancy, endometrial or cervical cancer, unexplained vaginal bleeding, gestational trophoblastic disease, distorted endometrial cavity, and acute pelvic pain, for example, pelvic inflammatory disease cervicitis. Progestin intrauterine device, active liver disease, it causes liver injury, and active breast cancer. Copper intrauterine device is contraindicated in Wilson's disease. Okay, in patient with the intrauterine device in situ, at the time of infection, intrauterine device removal is not required because its removal increases the risk of unintended pregnancy and does not affect treatment outcomes. Then primary infertility. Failure to conceive after a year of unprotected timed sexual intercourse in a nulliparous patient aged less than 35 for 1 year more than 35 years age, the time duration is 6 months. Before that, the time duration is 1 year. Diagnosis: first line imaging test is hysterosalpingogram. Okay, and then we can see for the anatomical defects in the uterus or fallopian tubes. Then breast cancer risk factors. The breast cancer risk factor modifiable ones are hormone replacement therapy, nulliparity, increased age at 5 live births, and alcohol consumption. Non-modifiable risk factors are genetic mutations of breast cancer in first degree relatives, white race, increasing age, and early menarche or late menopause. Most guidelines suggest routine screening mammography at age more than 50 due to increased risk of cancer with increased age. Then we have BRCA carrier risk. BRCA carrier status can be suspected if the patient has following: BRCA cancer diagnosis age less than 50 and ovarian cancer at any age. Diagnosis is testing for genetic mutations. Treatment is bilateral mastectomy. Okay. Then we have endometrial cancer. Endometrial hyperplasia or cancer risk factors are excess estrogen, obesity, chronic anovulative polycystic ovarian syndrome, nulliparity, early menarche or late menopause, and tamoxifen use. The clinical features are heavy, prolonged intermenstrual or post-menopausal bleeding. Evaluation is endometrial biopsy, which is a gold standard, and pelvic ultrasound is post-menopausal women. First, we do the intravaginal IV ultrasound. What does it mean? I think it is TVUS, transvaginal ultrasound. Then less than 4 millimeter, observe. Yeah, if we do the transvaginal ultrasound and you find the endometrial strip to be less than 4 millimeters, do observe the patient. If it is 4 millimeters or if more than 4 millimeters, then do the biopsy. Treatment is hyperplasia, that is progestin therapy or hysterectomy, and cancer hysterectomy. Tobacco use decreases the risk of endometrial cancer by stimulating the estrogen metabolism in liver and hence decreasing the estrogen levels. For patients on progestin therapy, follow-up is with repeat endometrial biopsy every 3 months. Copper intrauterine device, it looks something like this. Okay, it is 99% effective, can be placed up to 10 years, cause cytotoxic inflammatory response and kills sperm and ova. Not to be given in Wilson's or history of bleeding. So these are the strings, and causes endometrial toxic to sperm and ova. And this one is intrauterine device. Then we have Candida intertrigo. So these are erythematous plaques, and these are satellite lesions. Satellite lesions are basically lesions which are distant from the original site of infection, like over here. So presentation of Candida intertrigo. Intertrigo means the infection of the intertriginous area where skin overlaps skin. So erythematous beefy red plaques with inguinal folds within the inguinal folds, and there will be satellite lesions. Risk factors are immunosuppression, systemic corticosteroid use, and diabetes mellitus. Increased skin moisture or friction will lead to obesity and tight fitting clothing. Diagnosis is basically clinical. Confirmation by visualization of hyphae or pseudo-hyphae on microscopic examination of skin scraping from the affected areas. Treatment is with topical azoles, clotrimazole, and ketoconazole. Then we have genitopelvic pain penetration disorder. So genitopelvic pain or penetration disorder. Risk factors are sexual trauma, lack of sexual knowledge, and history of abuse. The clinical features are pain with vaginal penetration, distress, anxiety over symptoms, and no other medical cause. Treatment is desensitization therapy and Kegel exercises. Ovarian torsion. Risk factors are ovarian mass, women of reproductive age, infertility treatment with ovulation induction. The clinical presentation is sudden onset unilateral pelvic pain, nausea and vomiting, with or without palpable adnexal mass. Ultrasound, adnexal mass with absent Doppler flow to ovary. Treatment is laparoscopy with detorsion, ovarian cystectomy, and oophorectomy if the necrosis or malignancy. Any large mass more than 5 cm can induce torsion. Mature cystic teratomas, dermoid cyst common in premenopausal women, have an elevated risk due to heterogeneous composition. Seen on ultrasound has partially calcified mass, teeth, with multiple thin echogenic bands of hair. So, okay, these are mature cystic teratomas or dermoid cysts. Torsion pain causes increases by physical activity. Then we have mature cystic teratoma. Pathology is benign ovarian germ cells, endoderm, mesoderm, and ectoderm tissue. The clinical features most asymptomatic: ovarian torsion, struma ovariae subtype is hyperthyroidism, unilateral adnexal mass. Ultrasound will show complex cystic calcifications. Gross appearance will have sebaceous fluid hair and teeth. Management is ovarian cystectomy or oophorectomy. Then we have ovarian hyperstimulation syndrome. It is an iatrogenic complication of ovulation inducing medications. It is caused by overexpression of VEGF, which can result in bilaterally enlarged cystic ovaries with increased vascular permeability, for example, increased Doppler flow, which causes third spacing, for example, ascites and pulmonary edema. Features are abdominal pain due to ovarian enlargement by the multiple follicles, ascites, and respiratory difficulties. Ovarian hyperstimulation syndrome. Pathophysiology is increased HCG enhances ovarian vascular permeability, acute fluid shift to extravascular space. Clinical features include ascites, respiratory distress, hemoconcentration, hypercoagulability, electrolyte imbalance, multi-organ failure, for example, renal failure, and disseminated intravascular coagulation. Evaluation, fluid balance and monitoring, serial CBC and electrolytes, serum HCG, pelvic ultrasound, chest X-ray, and echocardiography. Management is correct by electrolyte imbalance, paracentesis or thoracentesis, and thromboembolism prophylaxis. Then we have herpes simplex virus, multiple painful genital ulcers. Features are tender inguinal lymphadenopathy, open ulcers, dysuria, sterile pyuria WBC present but bacteria absent, acute urinary retention due to reluctance to urinate, and lumbosacral neuropathy. Diagnosis is with a viral culture and PCR. Then we have urethral diverticulum. So this is a picture of that. Here you can see that this is vagina, and here, okay, so this is vagina, this is bladder, and the urethra that was supposed to go straight is making a small diverticulum like this. Okay, so this is urethral diverticulum. So abnormal localized urethral mucosal outpouching due to the recurrent periurethral gland infection along the anterior vaginal wall. It can collect urine post-void dribbling and with lower UTIs. Infection of diverticulum tender anterior vaginal wall mass. It is associated with expressed purulent or bloody urethral discharge. Presentation is dysuria, post-void dribbling. It does not increase with Valsalva. Urethral diverticulum. Definition: urethral mucosa herniated into surrounding tissue. Clinical features of dysuria, post-void dribbling, dyspareunia, and anterior vaginal wall mass, post-vaginal Bartholin cyst. Diagnostic tests are urinalysis, urine culture, MRI of the pelvis, and transvaginal ultrasound. Gestational age assessment. First trimester ultrasound with crown rump length measurement is the most accurate method of determining the gestational age. In a woman with reliable last menstrual period and normal menses, the estimated date of delivery and gestational age are based on last menstrual period. In the estimated gestational age varies more than 7 days in the first trimester and more than 10 days in the second trimester. The ultrasound estimated gestational age is used rather than last menstrual period. So ultrasound assessment of gestational age, gestational sac diameter, gestational age in weeks, 4.5 to 6, and accuracy with or without 5 to 7 days. Crown rump length, At 7 to 10 weeks, it is more or less, what is that? Okay, so crown rump length is measured at 7 to 10 weeks. The accuracy is plus minus 3 days, and 11 to 14 weeks, the accuracy is plus minus 5 days. It is the most accurate measurement in the first trimester. Then biparietal diameter, head circumference, and femur length at 14 to 20 weeks has a accuracy of plus minus 7 days, 21 to 30 plus minus 14 days, and over 30 days it has an accuracy of plus minus 21 to 28 days. So this is the crown rump length. Okay, from here to here. This is the crown rump length. Crown rump length is a measure of length of human embryos and fetuses from the top of the head crown to the bottom of the buttocks, that is rump. Okay, then we have anogenital warts in children. Treatment is if they are asymptomatic, do the observation. If they are symptomatic or unresolved disease, topical treatments like podophylotoxin and surgical removal can be done. Anogenital warts with the condyloma acuminata in children. Etiology is human papilloma virus infection. Transmission is sexual abuse. Auto-inoculation from other sites and prenatal or perinatal. The clinical features are pink flesh colored, verrucous plaques, papules and plaques. Asymptomatic are most common and periodic friable lesions. Management is sexual abuse. Treatment especially age more than 4. So how much more is left? We are about done. So we have done that, right? Yeah. Then we have physiologic leukorrhea. It is a white odorless cervical discharge composed of cervical mucus and normal vaginal flora and vaginal squamous epithelium. Its discharge increases mid-cycle. It presents without manifestation of infection such as pruritus, erythema, pain, or malodorous discharge. So this is basically a picture of menstrual cycle. We have talked about that before. So in the follicular phase, we have primary follicle, then that becomes secondary, then tertiary, then ovulation happens. And during the ovulation, the estradiol peaks, and so does the luteinizing hormone, which is not drawn over here. So with estradiol, it is only mid-cycle when estradiol is stimulating the nasal LH. Otherwise, it decreases that. Then, along with estradiol surge, the cervical discharge also increases, and progesterone increases in the luteal phase thanks to the corpus luteum, and then that becomes corpus albicans, and the progesterone level falls down, estrogen level falls down, and so does the cervical discharge. And in the endometrium, during the follicular phase, there is a proliferative phase. After ovulation, we have secretory phase. Ovarian hypertrichosis, a cause of virilization in post-menopausal women, associated with signs of insulin resistance, normal LH and FSH levels. Diagnosis is ultrasound, solid appearing, and large ovaries. Okay, then imperforate hymen. In this condition, we'll have hematocolpos, as you can see here. Pathogenesis is incomplete degeneration of hymen. Clinical features are cyclic lower abdominal pain, bulk symptoms like defecation or urinary dysfunction, primary amenorrhea, suprapubic mass like uterus, and blue tinged vaginal mass. Management is with hymenal incision and discharge. Ruptured ovarian cyst. Look for severe sudden onset abdominal pain following sexual intercourse or strenuous exercise. Although hemoperitoneum does not typically occur with the ovarian cyst structure, however, it can occur in the patients who are on anticoagulation. Physical examination is lower quadrant tenderness. Diagnosis is abdominal ultrasound. Simple thin wall cyst with a free fluid in pelvis. Management in hemodynamically stable patient, do the observation. If the patient is hemodynamically unstable, perform the surgery. Then we have intimate partner violence screening. It should be done in all women of childbearing age at routine medical visits because they have increased stresses in need for more finances. Okay, so routine postpartum screening for intimate partner violence starts 3 to 6 weeks after the delivery. Okay, so this is the hematocolpos, like this is the blood accumulating. Posterior expansion causes increased defecation pain, incomplete evacuation, and tender anterior rectal mass. Hymenal incision drainage is the treatment. So intimate partner violence evaluation is routine annual examination, suspicious signs with bruising, and prenatal visits. Consequence is homicide, mental health problems like post-traumatic stress disorder, unintended pregnancy, pregnancy complications like abruptio placenta, and sexually transmitted infection. Management is safety planning, for example, local shelter referral and psychosocial counseling. What are the osteoporosis risk factors? The non-modifiable ones are advanced age, postmenopausal, low body weight, white or Asian ethnicity, malabsorption disorders, hypercortisolism, hyperthyroidism, hyperparathyroidism, inflammatory disorders like rheumatoid arthritis and chronic liver or renal disease. Modifiable ones are smoking, excessive alcohol intake, sedentary life, medication like glucocorticoid and anticonvulsants, vitamin D deficiency, inadequate calcium intake, estrogen deficiency, for example, premature menopause, hysterectomy, and oophorectomy. The last topic is idiopathic intracranial hypertension, which is also called pseudotumor cerebri. Risk factor obese women of childbearing age, medication like retinoid, tetracyclines, and growth hormones. The clinical features are headache, vision loss and enlarged blind spot, pulsatile tinnitus, diplopia palpi with Wilson's nerve CN6, and papilledema. Diagnosis is with the neuroimaging and lumbar puncture, elevated opening pressure. Treatment is with the weight loss and acetazolamide. And here we go, we are done with the gynecology. Until next time, Allah Hafiz, Himalaya, and take